Good morning. I'm Steve Orbaugh from the University of Pittsburgh, and I'll be discussing with you regional anesthesia, in particular peripheral nerve blockade, for the next 40 or 45 minutes. I don't have anything in particular to disclose, and I'd like to just briefly mention our objectives, which will be to describe the risks and benefits of regional anesthesia and peripheral nerve blockade, describe contraindications to the blocks. We'll talk about the anatomy for the common blocks that we are discussing and list appropriate blocks for different orthopedic surgeries, as well as the common and uncommon complications of each type of block. There are a lot of potential benefits of peripheral nerve blockade, including less postoperative pain, of course, is the primary indication for doing this, but that translates into a lot of other benefits, such as receiving less opioids with many less opioid side effects, such as postoperative nausea and vomiting, postoperative sedation. At times, you may use peripheral nerve blockade to avoid airway manipulation if somebody wishes not to be intubated, say an opera singer, or if somebody has particularly bad dentition and you'd rather not put a tube in there. It may not be appropriate always to avoid a difficult airway by using peripheral nerve blockade simply because the block may fail. But there are times when you may choose to avoid airway manipulation by using a peripheral nerve block. There are other potential benefits too. Many of them were summarized in a series of investigations that were done back in the mid-2000s. This is one of them by Dr. Hadzik and his colleagues at Nysura, where they looked at peripheral nerve block in the form of an infraclavicular block versus general anesthesia for hand surgery, and they evaluated the impact of the block on outcome variables for surgical outpatients. And they found a lot of good things with the nerve block, that the patients who received the block were much more likely to bypass the recovery room, about 80% versus 25%. Pain was present in only 3% of the peripheral nerve block patients versus about 43% of general anesthesia patients. And importantly, discharge times were significantly shorter, about 100 minutes, so more than an hour and a half earlier. In a subsequent study for shoulder surgery, it was about 2.5 hours earlier, which means a lot to patients, particularly in the ambulatory setting. Here's some of their data, and you can see here that such annoying aspects of general anesthesia as nausea and vomiting, sore throat, poor concentration were all significantly lower with regional anesthesia. There are some disadvantages as well. Some people are very afraid of needles and may need to be convinced that it's reasonable to proceed and that their risks are relatively low. It's important that you not change people's minds, but at least give them a good summary of risks and benefits so that they understand what the overall impact of this may be, and also that they stand to receive a lot of benefits from it. It does take some extra time to perform nerve blocks, which in a busy practice is an issue. It also requires personnel that have been trained and understand how to do blocks or assist with blocks, so there is a significant input if you're going to run a regional anesthesia service. We find that remuneration is not always tailored to regional anesthesia, but there are ways to bill appropriately so that you can receive a reasonable amount of remuneration so that this is not a money loser, so to speak. And of course, there are side effects and contraindications that we'll discuss with each specific block. Typically, we want a long-acting peripheral nerve block. I'm not going to discuss catheters simply because we don't have the time, but we do have the option for most of the blocks we'll discuss to utilize a continuous block. But when we're talking about single-shot blocks, we have the choice between long-acting and short-acting local anesthetic. So the short-acting agents typically are going to act in the duration of 3 to 4 hours. Lidocaine and mepivacaine would be the agents that we choose here. If you want a longer-acting agent, and most of the time we do for postoperative pain control, lasting somewhere between 8 and 12 hours, both bupivacaine and ropivacaine are reasonable choices. Additives can also add an additional 10 or 20%, such as clonidine or epinephrine, specifically for bupivacaine or lidocaine. In recent years, dexamethasone has been gaining interest as a possible additive, which can increase the duration of the block by even more than 50%. I don't endorse that. I'm not sure that we've done all the safety studies that we need to make certain that the dexamethasone is safe to inject, but certainly more and more practices do seem to be integrating that. How do we do regional anesthesia? Well, we can do many different types of techniques for guidance. The paresthesia technique, which I think is largely an anachronism. Transarterial technique applies to axillary block only, and probably also is an anachronism in this day and age of imaging. And then much more commonly in this day and age, nerve stimulator technique, and with increasing emphasis on ultrasound localization, which I think has really been spreading like wildfire since about 2003 in North America, for good reason. Let's talk first about nerve stimulator, and then we'll talk about some advantages of ultrasound. The nerve stimulator allows us to, with fair precision, localize nerves. These little boxes, these little mechanisms have a linear output with a digital meter and a variable output control with a relatively short stimulation pulse. The polarity is marked, so you're always stimulating with the cathode as opposed to the anode. In prior days, you could choose either, but it makes more sense to stimulate with the cathode because you can do so with a lesser degree of current. And they have a feature called a constant current output, so that if you set a particular current and the impedance in the system changes, the voltage will automatically be adjusted to keep that current output at what you had previously set. So what do we control with the nerve stimulator? Well, typically the current in milliamperes, and we like, if we're using a peripheral nerve stimulator for localization of a nerve, to find the current threshold somewhere between about 0.3 and 0.5 milliamperes, and that tells us our needle tip is close to the nerve. Less than 0.2 is probably intraneural by some studies, and therefore we should pull back if we have such a low threshold. The frequency is usually 2 hertz. It can be 1 hertz, but that seems to be awfully slow. So I think for convenience, 2 twitches per second is more convenient and more sensible to use. The pulse duration is usually preset at 0.1 milliseconds for many of the older nerve stimulator boxes. The newer ones allow you to adjust the pulse duration. Typically, 0.1 milliseconds is appropriate for stimulating a motor nerve. If you wish to stimulate purely a sensory nerve, a longer pulse duration, such as 0.3 or even 0.3 or 1 full millisecond, is more appropriate. There's not a lot of clinical indication to stimulate sensory nerves, but one example is the saphenous nerve in the lower extremity. Ultrasound really came onto the scene in about 2003 in the United States. It had been used for almost a decade in Europe, particularly in Vienna before that time, but a number of things have made it easy to apply. These bedside units have become cheaper, although, of course, you can buy very nice ones, but in general, compared to the cart-based units of the 1990s, these are cheaper, they're portable, they have higher and higher fidelity, the images have become fantastic, and we can get real-time imaging of the nerve, the needle, and the placement of local anesthetic. The efficacy here is at least as good, if not better, than peripheral nerve stimulation. And by 2009, a number of studies suggested that the efficacy was better, that is, block success was better with nerve stimulation. The more accurate placement of local allows us to reduce the block time, to shorten the onset time of the block, and even increase the duration of the block. In addition to that, we can use lower doses of local anesthetic and get fewer chances of vascular puncture, which can translate, and has translated, into reduced systemic toxicity related to local anesthetics. How do we keep people safe when we do regional anesthetic blocks? Here's a sort of a laundry list of general principles. We should keep people relatively awake enough, even though we give them anxiolytics and something for pain, typically in the form of midazolam and fentanyl, occasionally a little propofol. We should avoid over-sedating them so they can report their experiences to us. This is an ASRA recommendation. We should aspirate continuously while we're localizing the nerve to avoid intravascular injection. We should administer local anesthetic in small aliquots and observe the patient for 15 to 20 seconds in between those 3 to 5 milliliter aliquots so that we can, in fact, judge whether there's any systemic toxicity occurring. We should also ask the patient during injection if there's any pain, which may indicate the needle is too close or even intraneural. Short bevel needles are less likely to penetrate a nerve, so they should always be used as opposed to long bevel type needles. Ultrasound is my recommendation for needle guidance to improve safety, particularly with local anesthetic systemic toxicity, and I use ultrasound for all of my nerve blocks. Yet I still think that peripheral nerve stimulation is an acceptable technique. One should prepare for local anesthetic toxicity by knowing where the lipid rescue kit is, so to speak, and also have a checklist available either on the block cart or in the block cart so that this can be rapidly administered as a specific antidote for any severe local anesthetic systemic toxicity. One should know the anatomy and the common complications of each block. If there's pain on injection or paresthesia, stop the injection. The needle should be pulled back and gently reestablish injection and make certain that the pain is gone at that point. Some would recommend stopping the block entirely, but I think most practitioners believe that if you pull back and there's no further pain, you're probably safe to proceed. And lastly, ASRA recommends in their guidelines to utilize epinephrine as a vascular marker to reduce the chance of local anesthetic systemic toxicity. There are some contraindications to peripheral nerve block. If patients don't want it, they shouldn't receive it. If they can't cooperate, likewise, they shouldn't receive it. And there is a gray sort of line there. For instance, in children, general anesthesia is an appropriate way to obtain cooperation for a peripheral nerve block because a 3-year-old can't cooperate, but yet they may get a great deal of benefit from the block itself. Local infection, certainly you don't want to put a needle through an infected area. Systemic infection, I think more of a relative contraindication, but for the most part, there should be at least some treatment established and the patient should be hemodynamically stable before initiating a peripheral nerve block in someone with systemic infection. If there's pre-existing nerve injury, that's a relative contraindication. Our data here is not great, but the ASRA recommends avoiding nerve block in people with pre-existing nerve injury. And if you do have to do a block because you think the benefits outweigh the risks, the patient should be informed of a potential increase in risk, and you should consider reducing the dose, reducing the volume, reducing the concentration, and avoiding vasoconstrictors. There are recommendations for coagulopathy, particularly for neuraxial blocks, but deep blocks may also come under this heading. In particular, I would say, of the blocks we're discussing, we should avoid in patients with a coagulopathy doing a lumbar plexus block or paravertebral block until the coagulopathy has been corrected. Other more superficial blocks one may undertake as necessary if the risks are outweighed by the benefits. And then there will be some other specific risks and contraindications we'll talk about with particular blocks. So let's start with the interscalene block. This is the highest approach to the brachial plexus and typically affects C5, 6, and 7 with sparing of C8 and T1, which means the hand intrinsics will be spared. The patients can often still move their hand, and the intermedial aspect of the hand, wrist, forearm, and upper part of the arm will be spared. And shoulder surgery doesn't usually involve those, so it's not a problem. But other lower arm surgeries about anywhere below the mid shaft or the humerus, probably not a good idea to use an interscalene block. The volumes here are usually 15 to 25 milliliters. With ultrasound, they may be a little higher without ultrasound, as high as 0.4 milliliters per kilo up to 40 milliliters. But again, ultrasound has allowed us to significantly reduce our volumes. For the shoulder, the C4 dermatome is important because the C4 dermatome involves the supraclavicular nerves, which are in the cape distribution, and the either the portals for arthroscopy or open incisions over the anterior aspect of the joint may involve the C4 dermatome. Fortunately, the interscalene block does frequently cover the C4 dermatome because of spread, either subcutaneously or toward the neuraxis. On the other hand, the lower approaches to the interscalene lower approaches to the brachial plexus, such as the supraclavicular block, infraclavicular block, probably will not cover the C4 dermatome and are less appropriate for shoulder surgery. If we're using a peripheral nerve stimulator, the biceps and deltoid twitches are most common and most appropriate, but any twitch that suggests you're stimulating the brachial plexus, such as triceps, pectoralis, or even brachioradialis, those are all acceptable twitches. Beware the posterior twitches from other nerves in the back, so that if you get a shrugging type of a response or the rhomboids are moving, you're probably with a branch of the brachial plexus or even as far posterior as the accessory nerve. You'll want to move your needle more anteriorly if you're using a landmark type of an approach. And if you happen to be stimulating the phrenic with hiccuping and the diaphragm moving, you're probably a little too far anterior to the interscalene groove and should move your needle back. Here's an image of palpating the interscalene groove just posterior to the sternocleidomastoid, and one can see the palpating fingers at about the level of C6, the cricoid cartilage. On this cross-section, you can see the same anterior scalene muscle, middle scalene muscle. The sternocleidomastoid overlies all of it, but when the head's turned, tends to move out of the way, and the skin stretches across this scalene plane. And in that divot right there, that groove is where the C5 nerve root is coming out, or visible in this particular picture. One must beware of the fact that a needle plunged past this nerve can get easily to the vertebral vessels or even to the neuraxis. An overlay of anatomy on a live model here shows the back of the sternocleidomastoid, the external jugular vein, and then here the brachial plexus just barely visible between the anterior and middle scalene muscles. On ultrasound, we see these large nodular nerve roots aligned vertically in between the anterior and middle scalene muscle. We have a similar image here. Typically, the needle comes from posteriorly through the middle scalene muscle and into the groove in this region, avoiding hitting these large nodules. There are some adverse effects and complications with the interscalene block, including diaphragmatic paralysis because of the effect on the phrenic. In probably 100% of patients at 20 milliliters or more of volume, and as you go down to 5 milliliters, this will diminish successively to about 45% of patients. But you can never completely eradicate the possibility of diaphragm paralysis, so one must be careful with patients with pulmonary compromise and doing the interscalene block. With low volumes and ultrasound. Hoarseness happens in 10% probably of patients. Horner syndrome in about 20% of patients. These are higher occurrences, though, if you use nerve stimulation and higher volumes. Pneumothorax should never occur in patients that are having interscalene block with ultrasound, but with vertical approaches in the prior era before ultrasound, there was an occasional pneumothorax. Local anesthetic systemic toxicity, which I'll repeatedly mention as possible complication, is usually reported less than 0.1%, less than 1 in 1,000, and should be even less than that, actually. In our practice, it's been vanishingly rare with ultrasound guidance. Nerve injury, depending on what you call a nerve injury, something very serious with loss of function, probably on the order of less than 1 in 1,000, but with minor numbnesses, it may be up to 8 or even 10%, rapidly diminishing over the ensuing weeks to months to virtually zero. And neuraxial injury was reported in the prior era before ultrasound. I don't believe this has been reported at all with ultrasound because of the oblique nature in which we bring our needle in and avoid the neuraxis. Let's move all the way to the other end of the brachial plexus now, to the axillary block, which is the lowest approach to the plexus. Actually, this is really a terminal nerve approach. We cover C7 through T1 very well here, but if we're not careful and specifically target the musculocutaneous nerve, we could miss C5 and C6, which would be of importance because the lateral aspect of the forearm and the root of the thumb would be at risk for not being covered by the anesthetic. Naturally, the axillary block, because it's low enough, does not cover the axillary nerve. I shouldn't say naturally, but sort of it's a little bit of a misnomer that we call it the axillary block because it doesn't cover the axillary nerve. So the deltoid will be preserved here. This is primarily used for elbow, forearm, wrist, and hand surgery in order to ensure that the medial aspect of the arm and the forearm are anesthetized. One should place a wheel of local anesthetic along the medial aspect of the upper arm where the nerve block is being conducted, because the medial antebrachial cutaneous nerve, the intercostobrachial nerve, and the medial brachiocutaneous nerve may not be in the neurovascular bundle where the local anesthetic is deposited for the other four terminal nerves that we're anesthetizing. Here we can use paresthesia technique, transarterial technique, nerve stimulator, or ultrasound guides. It lends itself to many techniques. Probably 5 to 8 cc's of local per nerve is appropriate, so we're looking at usually 20 to 35 milliliters of local anesthetic, although some studies have suggested much smaller volumes can be used if one has the accuracy of ultrasound guidance. If we use the nerve stimulator, we'll be looking for particular nerve stimulation motor function when we stimulate particular nerves. So the median nerve usually gives wrist and finger flexion, may also give pronation. The ulnar nerve gives motion of the hand intrinsics and thumb adduction, but also a ulnar deviation and flexion of the ulnar two fingers. The radial nerve gives wrist and elbow extension or finger extension. The musculocutaneous nerve gives elbow flexion via the biceps. And lastly, the intercostobrachial, as I mentioned before, one would require a subcutaneous wheel of local anesthetic. That, of course, is a pure sensory nerve and would not be stimulated. Why do we do multiple stimulations and delivery of local anesthetic to multiple nerves? Primarily because if you simply do this on 1 or 2 nerves, you get a less effective block. So the more places that you deliver your local anesthetic, that is to say if you go to all 4 nerves or at least 3 of the 4, you get a better block than if you only deliver your local anesthetic to 1 or 2 sites. In testing the axillary block, we have used in the past the mnemonic or the saying push, pull, pinch, pinch. The push was for the radial nerves, testing the triceps. The pull was for the musculocutaneous nerve, testing the biceps. The pinch over the hypothenar eminence was for the ulnar nerve, and over the thenar eminence for the median nerve. You could add a third pinch over the medial aspect of the forearm for the medial antebrachial cutaneous nerve. In this image, we see the plexus forming sort of the letter M, with one leg going to the musculocutaneous out to the coracobrachialis muscle, and these 2 limbs coming from the medial and lateral cords going to make the median nerve, and then medial back here, coming off the medial cord, is the ulnar nerve. We can't really see the radial nerve here because it's behind the artery. This cartoon shows the approach that we typically use, with the median and the ulnar nerve being closer to the skin, or what I call anterior, anterolateral for the median nerve, anteromedial for the ulnar nerve, and then more posterior and medial for the radial nerve toward the triceps, and more lateral and deep for the musculocutaneous nerve, which is up toward the biceps and not in the neurovascular bundle as shown right here. On ultrasound, we see a very similar pattern. Median and ulnar nerve anterior and toward the skin, ulnar more toward the triceps, which is medial, radial nerve posterior and toward the triceps, which is medial, and then the musculocutaneous is quite deep and lateral. Here we see the needle brought in juxtaposition to the musculocutaneous nerve. This is a reminder that with gentle probe pressure or finger pressure, it's easy to occlude veins and, unfortunately, even on ultrasound, inject into them if you're not aware of where they are. Your aspiration isn't very effective if you aspirate and the veins have been collapsed. Here we see an image of the axillary artery, median nerve, ulnar nerve, and right next to them, we can't see them in this picture till we take the probe pressure off. There's a pretty good sized axillary vein or two axillary veins. It'd be easy to put your needle in there as you're attempting to block the ulnar nerve and not realize you were injecting into the vessel. What are the complications and adverse effects of the axillary block? Well, for one, I want to mention again that you have to seek the musculocutaneous nerve separately. It's not in the neurovascular bundle. The patient has to be able to bring their arm up, and if they can't abduct at the shoulder, it's going to be difficult to do this block. Local anesthetic systemic toxicity I mentioned before with interscaling, probably in the order of 1 out of 1,000 or less in the pre-ultrasound days, but much more rare. Several studies have shown LAST to be quite rare and much less likely if you have ultrasound versus nerve stimulation in the last few years. Neural injury on the order of 1 in 100 to 1 in several thousand, and this is again going to depend on your definition. Minor transient numbness is probably on the order of 1 to several percent. Severe injury with loss of function, much less likely to occur, probably on the order of 1 in several thousand. Femoral block in the lower, as we move to the lower extremity, is usually used for knee surgery or surgery of the femur or possibly medial ankle surgery. This is usually done at the level of the inguinal crease, which is going to be several centimeters, probably 4 to 5 centimeters below the inguinal ligament. At that femoral crease, you're a little closer to the nerve, and you palpate the femoral artery and move 1 to 1.5 centimeters lateral to it, or use ultrasound to localize the nerve. Here we're looking for a rectus femoris contraction, which is the so-called patellar snap. Medial contractions when you're using nerve stimulation, that is the sartorius contraction, may not be as accurate or as useful to get a good block. The typical femoral block usually uses 15 to 20 milliliters of local anesthetic. Higher than that when you're using nerve stimulation, and if you want to cover the lateral femoral cutaneous laterally, typically a larger volume such as 30 milliliters will be used. Back in the 70s, the term 3-in-1 block was coined, which implied you were covering the femoral, lateral, femoral cutaneous, and obturator. We've found out over time, though, that that block typically does not cover the obturator with a great deal of success. So if you want to cover the obturator, a lumbar plexus block or a definitive obturator block with ultrasound is more appropriate. Here we see a cartoon showing the femoral nerve coming under the inguinal ligament, just lateral to the arteries, which aren't visible here, but you see very rapid branching. For the most part, this nerve branches within a couple of centimeters of the inguinal ligament, and by the time we're ready to block it, whether with ultrasound or not, even though this looks like a single nerve, it's probably a constellation of branches that are held closely together. You can see it's overlain by a couple layers of fascia. Fascia iliaca immediately atop this iliopsoas muscle and across the nerve going under the vessels, and up here another strip of fascia is probably the fascia lata, although I don't see it particularly well. Those are the 2 layers of fascia one goes through with the needle to do a femoral nerve block. Adverse outcomes with femoral block include, again, intravascular injection, not very frequently reported, but in the days before ultrasound, you could get blood back 15 or 20% of the time when you were attempting to do femoral nerve blocks because of crossing vessels that were not necessarily palpable in terms of pulsation. Bleeding or hematoma, very rare, but could occur, especially with catheter placement. Infection, vanishingly rare with single-shot nerve block, but can occur with peripheral nerve block catheters, and this is the most likely site to get infected, probably on the order of 0.1 to 1% chance of significant infection. Peripheral nerve injury may happen between 1 in 200 with catheters, all the way up to 1 in 3,000 with single-shot nerve block. Sciatic blocks can be done at multiple different levels. The sciatic nerve is, of course, of great importance to the lower extremity. It includes innervation of all the structures below the knee except the skin over the medial calf and ankle. Also has input into the hip joint as well as the knee joint, along with the femoral and the obturator nerves. At the ankle, only the sciatic nerve is involved in joint innervation. Sciatic nerve block is useful for hip, major knee, and foot procedures, and is noted here, sensation to the posterior knee, leg, and foot, as well as motor to the hamstrings and all of the leg below the knee in terms of musculature. There are a lot of different approaches. We're going to go over each of them in turn here shortly, and you may either use a single shot or a continuous catheter, which is true also for the femoral and for the popliteal fossa. Actually, for all of the blocks we've talked about, a single shot or continuous catheter may be used. In this diagram, you see the piriformis muscle under which, or out from under which, the sciatic nerve runs, and we'll see some ultrasounds that make that more clear as well. Again, here's the piriformis muscle and the sciatic nerve coming out across the short rotators of the hip between two bony prominences that will be more obvious on ultrasound. With ultrasound, placing a curved transducer that is a curvilinear low-frequency transducer at the bottom of the buttock and aiming somewhat cephalad, you can see two humps of bone, the ischial tuberosity and the greater trochanter, in between which is suspended a layer of fascia, and this sort of large hyperechoic ovoid structure is the sciatic nerve, surrounded by a little bit of space called the subgluteal space where one can place local anesthetic. This is the classic approach with a line drawn between, that is the Winnie approach, also derived from Labatt, line between the greater trochanter here and the PSIS here, and then a second line from the greater trochanter to the sacral hiatus, a line from the midpoint of the first, it's a perpendicular drop to the second, gives you approximately the region to insert the needle. Here we see this in both diagram and in a photograph, and you can see the needle point which should come directly to the sciatic nerve. In practice, this often takes a few redirections to get right to where you're going. With the infragluteal approach described by Benedetto in 2001, there's less flesh to go through, less tissue to divert your needle into, and so I prefer this. We typically do most of our sciatic blocks as infragluteals. Here we, by palpation, find the greater trochanter and the ischial tuberosity, draw a line between them, find the midpoint and drop 4 centimeters down to palpate the groove between the vastus lateralis and the hamstrings at this point, or actually the lower fibers, sometimes at the gluteus are there also. But palpating that groove, one then enters at about a 45-degree angle. With ultrasound, it's even more simple because it's usually pretty easy to locate the sciatic nerve about 3 to 4 centimeters deep just at that infragluteal region. Here we see a needle placing local anesthetic just under the nerve. In large people, this may not be as easy, and if you can't find the sciatic nerve in the thigh, then I would recommend using this is with a linear high-frequency transducer, but if you can't find the sciatic nerve easily in the thigh, then one can move up to the lower buttock and use the low-frequency curvilinear transducer. Adverse effects mirror what we discussed previously, the LAST, and probably less than 1 in 1,000 patients, and even fewer than that with ultrasound. Peripheral nerve injury on the order of 1 in several thousand for single-shot injections of the sciatic nerve. The popliteal fossa block is simply another type of sciatic block, but working a little bit lower, primarily used for foot and ankle surgery. A catheter can also be placed here, although one has to be wary of where the tourniquet is placed. If the tourniquet is placed on the calf, it makes sense to use a popliteal fossa catheter, but for the higher tourniquet on the thigh, one may wish to use a higher catheter above the level of the tourniquet. After the sciatic nerve splits, the tibial nerve continues straight down and innervates the calf muscles, causing foot plantar flexion. The peroneal nerves move laterally around the fibula and around the fibular neck to innervate the peroneal muscles, causing eversion, and then also the dorsum of the skin of the foot, whereas the tibial passes posterior to the medial malleolus, innervating the sole of the foot, including the short, proper muscles of the sole of the foot. This can be accomplished with either prone positioning or lateral positioning. When a patient is prone, one feels the tendons on either side, makes a mark in between them, and then goes just cephalad 7 to 10 centimeters, moves over 1 centimeter to block the nerve. Here we see the bifurcation of the peroneal and the tibial. The vessels are deep and medial. We can just barely see them back here, and that's a question that's not infrequently encountered on the boards. So if one encounters blood, one is too medial and too deep and should pull back and aim a little bit more laterally. Here we see on ultrasound the peroneal nerve and the tibial nerve just separating. This is an ideal place to place the local anesthetic, as at this point the capsule that surrounds both of these nerves is often still intact, encapsulating and directing the local anesthetic around both of these nerves, and one can use a lower volume with a faster onset under those circumstances. Here they're a little further separated. That capsule is probably no longer intact around them. They probably have, each of them have their own perineural sheath, but one can still block at this level. With a little bit of adipose around the nerves, they stand out pretty well. On the other hand, if a person is very lean with low body fat, this nerve may be impacted against the semitendinosus muscle, may be significantly more difficult to identify. Here are the landmarks for the posterior approach, again, making a triangle with the base of it between the two tendons. Find the midpoint, move up 7 to 10 centimeters, and over one, somewhere between 5 and 10, but I actually use a little bit higher, 7 to 10, not the 5. And then, because I'm afraid it may have already bifurcated at that point, but getting a little bit higher up here, usually you find the nerve before it's bifurcated. On the other hand, with ultrasound, you can see both limbs of it. It's a little bit easier. There's also the ability to do this with the patient lying supine, in which case one comes in to the groove between the vastus lateralis and the biceps femoris, which is palpable about 7 centimeters above the upper pole of the patella. Bring the needle in and then angle downward about 45 to 60 degrees. And if one goes a little bit less than that, the vessels are here. Again, they are deep and medial to the nerves, which are encountered here. With a nerve stimulator, turning the stimulator on often causes the biceps femoris direct stimulation as you pass through it. And then when you exit it, the stimulation will stop. And within 1 to 1.5 centimeters, one should encounter the peroneal nerve, which will be the more lateral of the two nerves. On the other hand, again, this can be done with ultrasound, in which case it's relatively simple, usually to localize the nerves and bring the needle in directly to them. Adverse effects of the popliteal fossa block include, again, local anesthetic toxicity, nerve injury, which may be a little higher than the high sciatic for reasons I'm not exactly certain of. And remember that this covers almost all of the foot except the medial aspect of the ankle and to some variable degree the medial aspect of the forefoot. If necessary and there's any medial work being done, it makes sense then to do a saphenous nerve block also to cover the foot. And this is indicated, again, for foot or ankle surgery with the medial aspect of the foot involved. One can do a subcutaneous injection, as we used to do in the old days, with the infrapatellar region right here shown, or we can do it at the medial malleolus. Unfortunately, these are probably only 50 to 70% successful. A nerve stimulator can be used to block under the sartorius with a directed sensory stimulation and placed in the local anesthetic. That way, that has a higher chance of success than a blind technique. And I think the most accurate technique at all is to use ultrasound guidance in the adductor canal about the mid-thigh level. At the interface of the sartorius muscle and the vastus medialis, one can localize the femoral artery. The vein is underneath here, compressed, and just lateral to it lies the saphenous nerve, which is usually visible. If it's not visible, one can simply place local anesthetic on the lateral aspect or over top of the artery itself in this little fascial compartment here where the vessels lie. And of course, it's important to make sure that you're not injecting intravascularly when you do that. Let's move from the lower extremity now to the face. One can apply local anesthetic in several different places, and there's a line that runs through the pupil from the midpoint of the upper orbit through the pupil down to the sort of the malar or the eminence of the cheekbone down to the mentum, and the foramina for all three of these nerves, the supraorbital, the infraorbital, and the mental nerve, all lie along this line. So we can see it just a little bit better here. Subcutaneous injections at this point can cover the forehead, the entire cheek area, and the upper lip, or the chin area and the lower lip in order to provide pain relief for any kind of surgery that's done on the face. Adverse effects and complications here would include very rare nerve injury, very rare local anesthetic systemic toxicity since the volumes are so low. For neck surgery, we may choose to do a superficial cervical block either by itself, just for pain relief, or in concert with a deep cervical plexus block to provide complete regional anesthesia for certain unilateral neck procedures, such as carotid endarterectomy, thyroid surgery, or parathyroid surgery. We need to avoid bilateral block of deep cervical plexus because of the potential for affecting both phrenics or the potential for affecting both recurrent laryngeals. But for a unilateral surgery, both of these blocks combined can provide good post-op analgesia. Here for the deep cervical approach, you can see that the landmarks are to find the mastoid and the Chassagnac's tubercle of C6, make a line between them, and then drop 1 centimeter posterior to that, make another parallel line, and then palpate to find the C4 transverse process. This would be easier localized with ultrasound. So either by, and this of course C4 is at the level of the thyroid cartilage, contacting this and pulling back and delivering 5 to 7 centimeters of local anesthetic should provide a deep cervical plexus block. Here we see the same landmarks actually photographed on the patient, and once again, C4 is the target, the transverse process of C4. For superficial cervical plexus block, the landmarks are easy. You simply palpate the posterior aspect of the sternocleidomastoid muscle where all of these skin radicals come out. These, of course, are superficial and all go to the skin of the neck itself, the supraclavicular region, which we talked about previously, C4, and also then the occipital region and even to some degree the temporal region. Complications and adverse effects include what I discussed a moment ago, which is the ability to provide phrenic nerve blockade or to provide recurrent laryngeal nerve blockade, which is the reason not to do a deep cervical plexus block bilaterally. Superficial cervical plexus will not affect those structures because you're not likely to get deep spread. You can also, once again, get nerve injury or local anesthetic systemic toxicity because there are so many structures in the neck that one has to be careful of with injection. Let's move from the face and head and neck to the trunk, which will be the last region we talk about for peripheral nerve blocks. Here we're going to talk about the lumbar plexus block and then the paravertebral as well as the tap block. For the lumbar plexus block, we're really interested in blocking three components of the lumbar plexus, obturator, femoral, and lateral femoral cutaneous nerve. So leaving L1 out isn't that important, but L2, 3, L4 are very important to us here. These are usually utilized for hip surgery or possibly for knee surgery. This, of course, is a deep block. The plexus is embedded in the psoas muscle, so there's a significant risk of bleeding. And as with the paravertebral, which we'll discuss in a moment, the ASRA recommends that the anticoagulation guidelines that they promulgate for neuraxial blocks also be obeyed for the lumbar plexus and the paravertebral block. This block is usually placed at the L4 level, aiming for the transverse process and specifically seeking a quadriceps twitch. This can be done with the assistance of ultrasound to find the L4 transverse process or simply by landmarks. Here, a line between the iliac crests is the one landmark, and the line parallel to the spine 5 centimeters off the spine going through the PSIS is the other, and at the interface of those two lines one places the needle looking to contact the L4 transverse process. Again, ultrasound can help you do that visually. An obturator or sciatic twitch is undesirable here. They indicate that you may be a little more medial than you want to be, and that can cause problems with regard to spread of your local anesthetic to the neuraxis. A 20 milliliter volume is typical for this. Here we see a cartoon depicting the lumbar plexus, and again, the two branches from L1, not so important to us, but the LFCN, the femoral nerve, and the obturator are the three that are very important to us as far as lower extremity and particularly hip surgery. This is an ultrasound showing the transverse process of L2, L3, L4, so you can see how this could be used to guide your needle to the L4 transverse process, and then probably put the transducer down at that point and guide your needle with a nerve stimulator just a little bit deeper. In this particular individual, the lumbar plexus is visible in the psoas muscle. In most adults, it will not be. Only in a very thin person or a very young person are you likely to see the lumbar plexus very easily with this technique. Adverse effects may be a little more severe with this lumbar plexus block, including the potential for hematomas and bleeding, and also retroperitoneal and renal injury. Of greatest concern is the neuraxial spread of the injectate, which may actually become intradural and cause a high spinal with a relatively large amount of local anesthetic, which can in fact be life-threatening. And again, there's the potential for simple local anesthetic systemic toxicity and nerve injury, although this is very infrequently described with the lumbar plexus block. Paravertebral block involves blocking spinal segmental nerves at the chosen level. This can be done at several levels with small volumes, or it can be done with one large volume of 20 cc's, which will spread several levels above and below if delivered appropriately into the paravertebral space, which is illustrated right here. The thoracic paravertebral is much more common than the lumbar. Lumbar can be used in various circumstances for, say, fan and steel incisions or for cesarean section in someone that could not receive an epidural. But we see the paravertebral being used much more commonly in the thoracic region, unilaterally for breast surgery or open cholecystectomy or thoracic procedures with or without a continuous block by a catheter, or bilaterally for upper abdominal incisions, for midline incisions above the umbilicus, or actually through across the entire abdomen in the midline. Here we see a landmark procedure where the top of the spinous process is palpated in the thoracic region and marked, and then moving 2.5 centimeters laterally, one inserts the needle to contact the transverse process, and then moving caudate to the transverse process, advances the needle approximately 1 centimeter past that bony contact and injects the local anesthetic. And again, it may be a small dose and do this at several levels, or it may be a larger dose to cover several levels with one single injection. This can also be done with ultrasound guidance to visualize the transverse processes, and here we see the spread of local anesthetic. In this case, the needle was brought in just in juxtaposition to the transverse process, being careful not to get low enough or deep enough to contact the pleura. Local anesthetic is injected and forcing the pleura down a little bit below the level that we see it at the next segment, and this implies spread within the paravertebral space. Epidural spread may occur in up to 25% of these cases, and rather than a complication, I would call it a side effect because it is so common. Usually one sees some bilateral effects, but occasionally this can result in hypotension. One has to be careful with the landmark technique or with the ultrasound technique of pneumothorax. These are usually small and self-limited. However, if one places the patient on general anesthesia and positive pressure ventilation soon afterwards, this could become a much more major pneumothorax. There's a minor risk of bleeding, but the vessels cannot be seen, cannot be easily compressed, and for that reason the ASRA recommends that the anticoagulation guidelines for neuraxial blocks also be followed for paravertebral blocks. And finally, of course, there's the potential for local anesthetic systemic toxicity. The last trunk block I want to discuss is the TAP block, the transverse abdominal plane block, which can be performed with landmark or ultrasound guidance. Here we're placing drug between the internal oblique and the transversus abdominis muscle. In this diagram you can see the little triangle of Petit, which on a very lean muscular person is easy to see. It's defined by the back of the external oblique muscle and the anterior portion of the latissimus dorsus. At the base of that triangle is the iliac crest, but palpating or visualizing this on a person with any adipose tissue at all on their side is very difficult. I would recommend using ultrasound for this. These unfortunately have a relatively limited duration with single shots, and when done in the mid-axillary line, as they typically are with ultrasound, really only result in analgesia from T10 approximately to T12 or L1. The upper abdomen is not well covered, and for that one would have to do a specific subcostal TAP block, which can also be done with ultrasound guidance. One can place catheters for more prolonged duration. If one has a midline incision that is to be anesthetized or provide analgesia for, then bilateral TAP blocks can be performed again with or without catheters. These are most useful for open cholecystectomies, and again that would require a subcostal incision. For umbilical hernia, that would be midline and probably require a bilateral. And for any midline GI procedure, one would, again, do a bilateral TAP block. Total abdominal hysterectomy and C-section are both lower abdominal procedures which are easily addressed with a TAP block. The superiority of the TAP block compared to intradural or epidural opioids is not necessarily well established. And here we can see the three different planes on ultrasound. These are relatively easy to identify: external oblique, internal oblique, and transversus abdominis. And it's in this plane right here where the local anesthetic should be deposited. One can actually see local anesthetic. Here's the needle, and here's the local anesthetic pushing these two muscles apart. Here's a schematic of the same thing: transversus abdominis, internal oblique, and here's the plane between them being filled with local anesthetic. In practice, people often put the transducer in the lateral aspect of the mid-axillary line, bring the needle in tangentially, because the tangential approach gives very little opportunity then to get into the peritoneum. This is the peritoneal cavity, so external oblique, internal oblique, transversus abdominis, and this plane between is where the nerves run, transversus abdominis plane, or TAP block. The adverse effects include getting an abdominal wall hematoma because small vessels like the epigastrics are running through the abdominal wall. At that point, it's important to use the Doppler to exclude that possibility before injecting, and also, of course, to always aspirate to make sure one is not in a vessel. The potential for neural injury is virtually nil with the TAP block, but local anesthetic systemic toxicity may occur, particularly with bilateral blocks and systemic absorption. The very last type of regional anesthetic we'll talk about is the IV regional block, which was first described by Beer in 1908 with Procaine. Here we utilize local anesthetic in a dilute form injected intravenously with a tourniquet on the upper arm. After exsanguinating the arm with an Esmarch bandage, we put the tourniquet on and place it 100 millimeters above systolic pressure, thereby keeping the vessels from refilling with blood, and therefore we create a space into which we place local anesthetic in a relatively large volume. The intravenous injection of local anesthetic blocks small local nerve fibers and nociceptors. It does not provide a dense block at, say, the median and ulnar nerves. It's primarily used in the upper extremity, but has also been described in the lower extremity. 50 milliliters is a typical dose for the upper extremity of 0.5% lidocaine. That relatively low concentration of lidocaine is used because if there were, in fact, a failure of the tourniquet, this might cause systemic CNS symptoms, but is unlikely to cause severe cardiovascular toxicity and would not likely be life-threatening. And that's a rare event, but nonetheless, we have to be concerned about it. The IV regional, unfortunately, because of that very, very low concentration, is limited to about a half an hour. The other thing that limits its duration is the tourniquet pain, so that about a half an hour, if the case isn't nearly completed, one needs to let the surgeon know that general anesthesia may need to be induced. A double tourniquet does allow for some prolongation, but it's not going to double the duration of the block, again, because of the particularly low concentration of lidocaine, as well as the severe ischemic pain that begins after about a half an hour. So this is typically useful for soft tissue work, such as a carpal tunnel release or a ganglion, perhaps, maybe even an extensor tendon repair that can be accomplished in a half an hour, but it's not going to be useful for ORAF or other major bone work. There's always the risk of systemic toxicity if the tourniquet is let down too early, so it should not be released until after about 20 minutes. Some advise that it be let down in increments, but I think after about 20 minutes, one tends to see very little in the way of systemic symptoms. However, if you release it before that, it is a possibility. And because of the short duration of the block, we get washed out of the lidocaine pretty quickly when the tourniquet is down, even though there's been some fixation to tissues. And again, the low concentration that we use, the minimal concentration, also causes a short duration. Additives may be used to improve the duration of analgesia, such as ketorolac, clonidine, and ketamine. Each of these may extend the duration of analgesia by several hours. So in summary, regional anesthesia and peripheral nerve blockade offers many benefits, including pain relief, reduced doses of opioids and their side effects, and improved patient satisfaction. As always, it's important to know the anatomy. Anatomy remains the cornerstone of regional anesthesia. Even in the day of ultrasound, we need to understand what the two-dimensional images mean in terms of the relevant anatomy. Patient safety always is paramount for us, and we need to observe the usual rules for keeping patients safe while we're doing peripheral nerve blocks. We need to understand the particular adverse effects of each block. And I just want to comment that ultrasound has become the localization method of choice, which allows us fewer needle sticks, less pain, higher success rates, lower doses, and less risk of local anesthetic systemic toxicity. Thank you.